Everyone, I'm going to start studying for my pediatric exam soon, so I'm going to try and make a video on each of these topics, maybe once a day or once every couple of days, depending on how much time I have. So let's start with general pediatrics. Here's some anthropometric stuff. So head circumference gain in the first year is going to be 12 centimeters, and there's a nice mnemonic for this. So in the first 3 months, the head circumference increases by 2 centimeters per month, and then 3 to 6 months it increases by 1 centimeter a month, and then 6 to 12 months it increases by half of that, so 0.5. And so there's a nice pattern, just cuts by half every time. And if you add it up, 2 times 3 months is going to be 6 centimeters, 1 times 3 months is 3 centimeters, and then 0.5 times 6 months is again 3 centimeters. So overall you have an increase in head size or head circumference of 12 centimeters in the first year. The fastest period of head circumference growth would be in that 0 to 3 month period, but specifically it's in the first 60 days. Routine HC measurement should be made at every well visit. For the first 2 years, you're going to use the WHO chart. After that, you use CDC. If they're premature, you use Fenton. And then if they have Down syndrome, trisomy 18, whatever, you're going to use the respective, charts. If they are premature and have a big head, think about hydrocephalus and do ultrasound to rule that out. Microcephaly, the best test to do would be MRI, and you suspect that if they have like a congenital infection like CMV or Zika virus. Most common cause for macrocephaly would just be benign familial microcephaly. So check the parents' heads. If the parents also have big heads, then it's probably benign. Okay, so let's see how I did. So 12 cm total, 6 cm in the first 3 months, then 3 cm, and then 3 cm in the last 12 months. So 6 to 12 months. First 60 days would be the fastest rate of increase. So that's the first 2 months. And then you should check it at every well visit until age 2. So I missed that. WHO under 2 years, CDC after 2 years. Vaccine schedule. So the vaccines given at birth, basically in Canada, or at least in British Columbia, we don't give anything, but in the US, they recommend the hepatitis B vaccine. If the mother has hepatitis B, in British Columbia, we would give the hepatitis B vaccine. We just don't give it to everybody universally. So if the mother has proven positive hepatitis B surface antigen, you're not only going to give the HBV vaccine, but you're also going to give the immunoglobulin or HBIG. I like to call it HBIG when I'm studying alone. So HBV plus HBIG. Now, if the mother has unknown hepatitis B serology, then you're just going to give HBV and wait on the serologies to return until you give HBIG. DTaP can be given up until 7 years, and then after that, you're going to give Tdap, which is different because you have a less immunogenic diphtheria component. DTaP, the absolute contraindication would be a reaction of encephalopathy following a prior administration. The live attenuated vaccines include MMR, VZV, or varicella, rotavirus, and Polio Salk, which is the oral version of the polio vaccine. And then there's, of course, a intranasal influenza vaccine that I think is also live attenuated. So let's see. So given at birth, hepatitis B, and then you can give nirsevimab as well if they're eligible for RSV. That's true. Hepatitis B and HBIG within the first 12 hours. So I forgot to mention that. DTaP up until 7 years. Tdap after 7 years. Encephalopathy is the contraindication for DTaP. And then the live vaccines are, as I mentioned, MMR, VZV, rotavirus, and oral polio Salk. Let's see. So the route of MMR, varicella, and IPV would be subcutaneous. MMR and PPD. PPD is the tuberculosis skin test. They can be given on the same day. There's no interference. However, if you are going to give them separately, you have to wait 4 to 6 weeks. MMR, varicella, not on the same day. Again, 4 to 6 weeks. Immunocompromised, you should avoid giving them live vaccines. And then if they have neomycin or gelatin allergies, you should avoid I believe it's the MMR vaccine. Okay. And then sometimes after giving the MMR vaccine, a kid will have joint pain, and that's usually due to the rubella component. It's not a concern. Okay, so let's see how I did. Subcu for MMR, VZV, IPV. No interference if you give live vaccines on the same day. If you don't, you got to space at least 4 weeks apart. Contraindicated in immunocompromised individuals, and then MMR contraindicated if you have neomycin or gelatin allergies. Special situations. So if the kid is about to travel, so 4 weeks away from traveling, but they are due for MMR, what you're going to do is give them MMR now, and then when they return, resume the routine schedule. MMR-V, which is the combined vaccine, versus MMR varicella separately. Basically, MMR-V has higher rates of febrile seizures. Pregnancy, you're going to avoid live vaccines, and then avoid if they have immunocompromised, so transplant patients or chemotherapy, for instance. Kawasaki's is a condition where you can be treated with IVIG, and you're just going to wait 11 months after the last administration before you give them live vaccines. Steroids, less than 2 weeks. You can give live vaccines. However, if you've had steroids for longer than 2 weeks and it's also been a high dose of steroids, then you want to avoid live vaccines because steroids are immunosuppressive. Nirsevimab, so basically if you are under 8 months of age, entering your first RSV season, then you can get RSV. Or if you are over 8 months, so I believe it's 8 to 19 months actually, 8 to 19 months, entering your second season, you can also get RSV, but it's if you are high risk. So maybe if you have some sort of lung disease or, again, immunocompromised. See how I did? Travel soon with MMR due, you give MMR now. And then once they return, they'll still need the 2 doses. You just resume it. MMRV has a higher risk of febrile seizures. No live vaccines for pregnant or transplant immunosuppressive patients. Oh, actually, I forgot to mention. So they still need protection because they're going to be immunocompromised. So what you're going to do instead is 4 weeks prior to their transplant or beginning of chemotherapy, you're going to give them 4 weeks, or sorry, you're going to give them the live vaccine. And then same for the inactivated vaccines, but you can give them a little closer to their dates. 11 months before live vaccines if they've had IVIG, steroids under 2 weeks do not contraindicate live vaccines. And then for RSV, if they're under 8 months or they're a little older, up to 19 months and with high risk, then you can give them RSV. Okay. First flu vaccine, age under 9, they're going to need 2 doses of the flu vaccine. Severe egg allergy and MMR, I think this is a contraindication. Severe egg allergy with actually, wait. No, I don't think this is a contraindication. I think it's fine. And then severe egg allergy with flu vaccine, it's fine. It used to be a contraindication. Prior anaphylaxis to flu vaccine, obviously you're not going to give someone anaphylaxis again, so that's a contraindication. And healthy children, I believe, if they are under 5, you can give them either Haemophilus B or strep pneumo vaccines. These are both encapsulated bacteria, so normally we just give them to kids with asplenia or immunocompromise. First flu vaccine, age under 9, you're going to give 2 doses, and I forgot to mention you should space them out 1 month apart. Egg allergy is not contraindication to MMR or flu vaccine, both okay. And then do not give someone anaphylaxis if they have allergies to like a vaccine. And then Haemophilus B and the pneumococcal vaccine is not needed if they're healthy and older than 5 years. But if they're under than 5 years, I think it's fine. Okay, developmental milestones are always a pain in the ass. I just randomly chose a couple. So let's talk about motor milestones first. So 2 months, they can bring their hands together and they can track with their eyes up to 180 degrees. And later on, they can track, 360 degrees. So they're not going to lose you if you just, move behind them. 4 months of age, they can roll front to back. And then 6 months, they can roll both ways. 4 months, of course, they don't have head leg anymore. 6 months sitting with support, also described as a tripod position. So they're basically putting their hands behind or in front of them so that they don't fall over. And they're also transferring objects hand to hand. Some sources will say that at 7 months they can sit without support or sit independently. Other sources will say that happens at 9 months. So regardless, 7 to 9 months. It depends on what percentile you're looking at. If you're like a developmental pediatrician or a pediatrician, you'll have a lower threshold than, for instance, a general family physician. 9 months they can pull to stand. They can also, I believe, do things like cruising, which is where they walk along a wall with their hand on the wall so that they don't fall. It just gives them a bit of support. 12 months they can stand well and they're taking their first steps. They have what's called a mature pincer grasp. So a pincer grasp is basically like pinching with the fingers, right? They can grab onto something pretty well. They have a weak pincer grasp at 9 months, and then before that, at 6 months, they develop what's called a raking grasp, where they have a crude way of pulling things towards them and grabbing onto things. Basically, it's like their whole hand sort of rakes things towards them. 15 months is where we start talking about like piling up blocks. So 15 months, 3 blocks, 18 months, 4 blocks, and then after 2 years, you can use a nifty rule, which is the age times 3. So for instance, 2 years of age times 3, they're gonna pile up 6 blocks. At 3 years, they're gonna do 9 blocks, and so on. 2 years also climbing stairs, but they're doing what's called marching time. So marching time is basically where they put 2 feet on a step before moving on to the next step. And this is going up and going down the stairs. At 3 years, they're alternating feet when they ascend. And then 4 years, they alternate feet when they descend. Also at 3 years, they do other stuff, of course, that like, for instance, riding a tricycle at 4 years, they can probably stand on 1 foot for a certain number of seconds, things like that. 5 years, they're using scissors, skipping, counting to 10, all that stuff. And then shapes, exams like to talk about shapes. So it sort of goes like vertical line or scribbling, then circle, square, triangle, cross, diamond, that sort of thing. Okay, social milestones is quite high yield because parents pay a lot of attention to this. So responding to names should happen around 6 months, and it's a red flag if that doesn't happen around 12 months. Stranger anxiety starts at 6 months as well. I get that mixed up a lot with separation anxiety, which is more around 9 months, which makes sense because 9 months you develop object permanence and you're looking for hidden objects and stuff like that. 9 months is also when they start using mama dada meaningfully, and then by 15 months they should have a couple words besides mom and dad. 18 months they'll have more words, 10 to 25, and then you'll get your 2-word sentences at 2 years, 3-word sentences at 3 years, and so on and so forth. Okay, so here's snapshots. This is from Peds Cases. It's a very well-known resource in Canada. I try to memorize or at least refer to this when I have to look up the milestones. I think it's really comprehensive. lots of stuff. I highly recommend it. Okay, developmental red flags. If they can't hold their head steady, that's going to be a 4-month red flag. If they can't sit alone, so that happens 7 to 9 months, and then rolling front to back is 6 months, but rolling both ways is, rolling front to back would be 4 months, but rolling both ways is 6 months. So overall, I would say this is a 9-month milestone if you combine these things. Walking independently should happen by 18 months. Standardized developmental screening. So like this is, I believe, these comprehensive milestone screens. That should happen at 9, 18, and 30 months. And developmental surveillance, I believe that's just like very high level check of like, are you holding your head steady? Are you able to sit independently? Can you take a few steps? That sort of thing. So in Canada, at least in British Columbia, we have what's called a Rourke baby record, or RBR. And that's typically what family physicians will use for surveillance. And this happens at every well child visit. Autism should be screened according to the AAP at 18 months and 24 months using either MCHAT-R or ASQ. And if there's any language concerns, speech or hearing, always get a hearing test first if they haven't had one already. There's different types, so depending on the situation and the age, the initial newborn screening test might not have been the best, most accurate thing. There's also, different changes that can happen with age. So getting a hearing test is usually the right answer for these sorts of exam questions. Okay, so let's see. So can't hold their head steady is 4 months, not sitting alone and not rolling, 9 months, not walking independently, 18, 9, 18, 30 months for developmental screening, and then surveillance at every visit, autism at 18 and 24 months. Great. Okay, hearing, we're going to screen that starting at, we want to identify a hearing problem by 3 months, and then if they have a problem, they should be in treatment by 6 to 9 months. Lead risk should be assessed at 1 year. This is a thing in the US because a lot of, places have really old houses, right? And then elevated blood level, there's no safe blood lead level, but the threshold is usually 3.5 micrograms per deciliter, or 35 micrograms per liter. Anemia should be screened at like 1 year, depending on risk factors. And then recreational drugs, I believe, is, I want to say 11 years. HIV, 13 years. Do that at least once in their life. Depression, suicide starting at 12. Earlier risk factors. Dyslipidemia is 2 time periods, so 9 to 11 years, and then 17 to 21 years. And it's hard to screen for this, but I think it's more so talking about like labs. So you do like a lipid panel and stuff. Okay, how did I do? So hearing 3 months, intervene by 6 months. Yep. A lead risk, I forgot the 24-month milestone. And then there's no safe level for lead, and the threshold is 3.5. Anemia, 1 year. Yep. And then recreational drugs, age 11, and you should do that at every visit. HIV, 13 years at least once. Depression, suicide, 12 years. And then for dyslipidemia, 9 to 11, and 17 or 21. Okay, lead level action threshold. So normally we're measuring a capillary blood lead level, but if the level is high, you want to confirm this with a venous level, which is more accurate. So under 3.5, remember our threshold was 3.5, so if it's under that, then it's totally fine. You don't need to do anything. 3.5 to 10, this is going to require venous lead level, I think, at 3 months, and then if it's 10 to 20, it's 1 month, 20 to 45, 2 weeks, and then over 45, 2 days or 48 hours. Let's get that. So 3 months, 1 month, 2 weeks, 48 hours. Great. Nutrition. So vitamin D is recommended to all breastfed infants at a level of 400 IUs per day. Not needed if they are taking enough formula, and I believe that's 1 liter of formula because that contains about 406 IUs a day. Iron, if they are exclusively breastfed, is started, I believe, at 4 months of age at a dose of 1 milligram per kilogram of weight per day. And then solid food should be introduced at about 4 to 6 months. And usually parents will do like allergenic foods, right? They're recommended to prevent allergies. So nuts, maybe fish, fruits, things like that. Breastfeeding is quite important to think about if the mother has conditions or is undergoing investigation. So radio contrast for imaging is fine. If they have acute mastitis or lactational mastitis, breastfeeding actually helps circulate the fluid and blood, and that might help reduce the duration of infection. Certain active infections, however, are contraindications to breastfeeding, including active tuberculosis as well as HSV. So if you see the HSV vesicular lesions on the breast, you shouldn't be breastfeeding. You should start treatment with acyclovir. Other infections, I believe, would be like HTLV, human T-cell-like virus, and I think brucellosis, which is more rare. Okay, so how did I do here? 400 IU a day for vitamin D, not needed if they have more than 1 liter of formula a day. Iron is 1 milligram per kilogram per day starting at 4 months, and then solid foods at 4 to 6 months, and that might reduce allergies. Okay, craniosynostosis. So this is basically like abnormal fusion of the sutures, and that can produce a big head or macrocephaly. Study of choice for an infant who presents with absolute microcephaly, and we mentioned that's going to be brain MRI. Anterior displacement of the occiput on one side, so the back of the head curves up on one side, and the frontal region on the ipsilateral side. So the frontal region also curves up. The ear is more anterior as a result of this, and that causes a parallelogram-shaped head. This is known as positional plagiocephaly. Positional plagiocephaly is on the next question stem, and this has been increased by supine sleeping. I think it's called the Safe Sleeping Campaign, because previously a lot of babies were sleeping on their stomachs, parents weren't aware, and that led to a high rate of sudden infant death syndrome, or basically just sudden infant deaths. 6-month-old with progressive head enlargement crossing percentiles, elongated in the anterior posterior diameter, shortened in the biparietal diameter, and there's ridging of the sagittal suture. So basically, when you look at them from the side, their head is really long. So here's their eyes, their mouth. But if you look at them from the front, their head isn't like very wide. So this is known as scaphocephaly. Child with enlarged head, similar to the father, no symptoms, normal cognitive function. Imaging shows prominent subarachnoid space in the frontal region. The diagnosis is benign familial macrocephaly. Anterior displacement of the occiput on one side, so once again the back of the head curves up. Frontal bossing on the contralateral side, so the frontal side curves down, and the ear is displaced more posteriorly on one side, so the ear was back on one side relative to the other ear, so something like that. And this is called unilambdoid synostosis, or posterior plagiocephaly. The most common type of craniosynostosis is actually this thing, which is scaphocephaly. So let's look at my answers. Brain MRI for microcephaly, positional plagiocephaly if they have the parallelogram-shaped head. The Safe Sleep Campaign had infants sleep on their backs, and that increased the rates of positional plagiocephaly. Scaphocephaly was the long head. Benign familial macrocephaly was associated with the big subarachnoid space in the frontal region, otherwise normal. Anterior displacement, so this was trapezoid head, and this was posterior plagiocephaly or unilambdoid synostosis. Most common was scaphocephaly. So there are some pictures. On the left is scaphocephaly. You can see the really long head when you view it from the side. In the middle is deformational plagiocephaly. Deformation referring to when they sleep on their back, their one side of the head is deformed, and this is all benign, so it will correct. And so this is this parallelogram shape. And then unilambdoid synostosis or posterior plagiocephaly is the trapezoid shaped head. Okay, catch-up vaccines. So like they miss something or they're like particular age, can they get a specific vaccine? So Haemophilus influenza is an encapsulated bacteria that can cause some serious infections, especially if you have asplenia or immunocompromised. Complications include stuff like sepsis, meningitis, pneumonia, bacteremia, septic arthritis. So can it be given older than 5 years? Usually we don't, unless they have, again, asplenia or HIV or other immunocompromise. Earliest age of HPV vaccine is going to be 9 years, and then up to 26 years is the recommendation. 4-year-old with a high fever, 103 Fahrenheit, I believe that's like 38 or 39 degrees. That's actually a moderate illness. So whether he can be vaccinated today, yes, he can, because there's basically only two contraindications to vaccines. One is you're really, really sick, which is not a 38 or 39 degree fever. And then the second contraindication is anaphylaxis. So in a previous question, they asked us, this kid had anaphylaxis to influenza vaccine. Can they get influenza again? Of course not, because they have a history of anaphylaxis, so they won't be able to get that vaccine. But in this case, this kid only has like a moderate illness, so he can be vaccinated. 9-month-old has only had 1 dose of rotavirus. Usually you have, I believe it's 2 or 4. I think it's 4. No, I think it's 2. And so he missed 1 dose, and can you get the second dose? So rotavirus has a very specific time window which you can give it. It's 14 plus 6 weeks up until 8 months. So you have to start it by 14 plus 6, and then you have to have your second dose at like up to 8 months. If you give it after 8 months of age, there's a higher risk of intussusception. So at 9 months, he's not going to be able to get the rotavirus vaccine. 11-year-old is here for HPV vaccine. How many doses are recommended? So if they're under 15, they get 2 doses. 15-year-old for HPV vaccine, if they're older than 15, they get 3 doses. So this is like the American guidelines. Actually, in British Columbia, where I study and live, the guidelines are a bit different. I don't remember exactly. I think it's 2 doses regardless of whether you are under or over 15. Unimmunized 4-month-old came for catch-up vaccine for rotavirus. So can you get rotavirus? He's never received a dose. So this is different from the 9-month-old who had 1 dose before. This is a 4-month-old who has never had it. So 4 months is 16 weeks, which is greater than that 14 plus 6 threshold. So he cannot start rotavirus anymore. So no. Let's see. So Haemophilus B influenza, Haemophilus B vaccine. You get 1 dose for unimmunized persons with functional or anatomical asplenia and HIV infection. HIV vaccine can be given up earliest 9 years. If they have moderate illness, you can give a vaccine. Only would like severe illness or anaphylaxis would be contraindications. So rotavirus, again, is like 14 plus 6 to 8 months would be the time window. You got to start it at 14 plus 6 and you got to end by 8 months. 11-year-old, so under 15, you get 2 doses. And I forgot to mention the time interval is 6 to 12 months apart. And then similarly, there's like a time interval for the 3 doses if you're 15 or older. And then 4 months old, because they are older than the 14 plus 6 weeks, they cannot start the rotavirus vaccine. Some more vaccine logistics. So a healthy 8-year-old received 2 doses of IPV before age 4. What is the best recommendation? So usually IPV is a 4-dose routine, I believe, and then I think they can get 1 more dose of the IPV. 2 months, and they have a complement component deficiency. What vaccine should be given? So thinking about the infections that require a complement to clear, that'd be Neisseria meningitidis, I believe. So you would give them the Neisseria meningitidis. Oh, is there a vaccine for that? At the 2-month, well, so obviously they're going to get their normal 2-month vaccines, but they will also get, I forgot what the vaccine is called, but they need something to protect them against Neisseria. I can't remember what it's called though. And then a mother declines vaccination was the best step. Basically, you just got to clear up any misconceptions, and if you have the discussion and they're still unwilling, you got to document comprehensively. Needle gauge size for IM vaccines, that's going to be 22 to 25 gauge. Household member is immunocompromised, can a 4-month-old receive oral poliovirus? So OPV is actually a live attenuated vaccine, and you should not be giving it if somebody in their house is immunocompromised. Special situations in which, so that's what I was thinking, the meningococcal vaccine. So that's what this earlier kid would need. The 2-month-old with the complement deficiency, they need the meningococcal ACWY vaccine. Situations, so basically, this is recommended if they're immunocompromised, so like HIV, if they have a complement deficiency, or they're taking drugs that cause like complement impairments, such as eculizumab. Needle length and gauge for sub-Q injection. So that's going to be a 5/8 inch. I think you can do 25 gauge, and the needle technique is 45 degrees. I remember that from one of my OSCEs. Okay, let's see how I did. Healthy 8-year-old, he had 2 doses of IPV before age 4. Yeah, you get 1 additional dose, and I think you get, it's usually like a 4-dose sequence, and it goes up to 9 years, I think. I can't remember. 2 months complement components. So yeah, they get the meningococcal vaccine. If you decline vaccination, you just got to explore it and then document. 22 to 25 for intramuscular vaccine. Immunocompromised, you cannot give OPV. And then meningococcal should be given if they have asplenia, HIV, complement deficiency, or complement inhibitors. For sub-Q injections, 5/8 inch, 25 gauge, 45 degrees. Great. Okay, so a bunch of like anemia, metabolic stuff. So dyslipidemia, we've talked about already. It's 2 age ranges, 9 to 11 and 17 to 21. An infant is feeding more than 1 liter of formula per day in addition to breastfeeding. He does not need vitamin D, because there's enough vitamin D in the formula. At what age do you start solid foods? 4 to 6 months. 7-year-old has a parent with total cholesterol of 300. What's the best next step? Basically, you just do a lipid panel. Yeah, there's like different types of dyslipidemias, so that will help you determine what type of dyslipidemia they might have. So the most common type is type 2, where you have a lot of cholesterol, but it's like either LDL or LDL and VLDL. There's other rarer types as well, like a lipoprotein lipase deficiency or ApoC2 deficiency, things like that. But the most common is like having a receptor problem causing an increase in plasma LDL or plasma VLDL. Exclusively breastfed, at what age should vitamin D be started? So I think it's like the first few days. And then exclusively breastfed again, daily iron, we mentioned that's going to be 4 months. All right, so let's see. 9 to 11 and 17 to 21 for dyslipidemia screening earlier if there are risk factors. Formula has a lot of vitamin D, so if you're taking 1 liter, you don't need to take additional supplements. 4 to 6 months, you should start solid foods. Fasting lipid profile, and then you repeat, right? You should repeat, right? Just to see the trend. Because one of the problems in pediatrics, and it's a bit of a tangent, but one of the problems in pediatrics is when you're trying to diagnose some conditions that require a bit of a trend or a baseline at least, you often don't have the baseline. So like for instance, acute kidney injury, it's hard to diagnose because you don't know what the kid's baseline was for like creatinine and PCR and things like that. First few days of life, you should start vitamin D, and then iron, you should start around 4 months. Okay, so this is a diagram of how cholesterol is synthesized and metabolized. So Let me change my pen color. So you start from acetyl-CoA, and then you produce cholesterol. You start off with VLDLs, and then that gets metabolized sequentially into IDL and then LDL. And then you start off with ApoB100, but then you add on like different apolipoproteins as well. And then the other way you can get cholesterol is from the diet, so the gut, and you start off with chylomicrons, and then you can release some of the lipids from that through lipoprotein lipase again. So there's different types of dyslipidemia. So type 1, you have high chylomicrons, and that's due to deficiency in LPL or ApoC2. Type 2A and type 2B are going to be your most common. As I mentioned, you have high LDL or high LDL and VLDL, and that's either due to a overproduction of VLDL or your LDL receptor is not working very well. So this is pretty important to know, at least in pediatric cardiology, and I think it's becoming more common. At least like we're picking this up more. Anyway, feeding milestones and infant mortality. So what age can child be given low-fat milk? And that's after 2 years of age. Because they need the fat to grow. So if you give them low fat from the start, they won't grow so well. Long-term complications of UV light, I mean, it's going to be like skin cancer, cataracts, things like that. What's the most common cause of death in infants from 1 month to 12 years? That would just be SIDS. And then there's like some good guidelines on what you should do to avoid SIDS. 2-month-old with excessive crying 3 hours every night, 3 days a week. This is basically what's called infantile colic because he's feeding well and growing well, no real like serious concerns or symptoms. This is infantile colic. It will self-resolve within, I think, 4 or 8 months. AAP recommends the initial dental visit at 12 months, so 1 year, or 6 months after the first tooth. Yeah. Most common causes of death in the first month of life, so it's not SIDS anymore, it's actually just congenital or chromosomal stuff. Okay, so low-fat milk after 2 years, cataracts, skin aging, and cancer from UV rays. SIDS is the most common cause of death from 1 month to 12 months. If they have these bouts of irritability at 3 to 4 hours every night, 3 to 4 days a week, and I believe there's additional criterion of at least 3 months in a row, then that's called infantile colic. It resolves by 4 months. Initial visit to a dentist is 12 months or 6 months after the first tooth. And then the most common causes of death would be congenital or chromosomal abnormalities. This is the first month of life.